It's a couple of minutes after 6, so I will get us started. So, just a very quick introduction. I'm Simone Dorsch. I'm one of the directors of the Stroke Ed collaboration, and I'm a physio by background, and I'm currently mostly do education and research. I'd like to acknowledge the country that I'm on. So, uh, this is Aboriginal land that we're on, and this is the land of the Camaragal people. And I'd like to pay my respects to elders past, present, and emerging, and to any Indigenous people that are here with us this evening, to pay my respects to you and to acknowledge that this is Aboriginal land. It's not been ceded and always was and always will be Aboriginal land. I'll hand over to Lauren to introduce herself, and then I'll introduce our guest speaker.
Thanks, Simone. My name's Lauren Christie. I'm an occupational therapist and co-presenter with the Stroke Ed collaboration. I work similar to Simone, predominantly in research, education, and also clinically in stroke rehabilitation. Thanks, Simone.
I'm absolutely delighted to welcome our guest presenter, Professor Neela Demeyer, we're absolutely thrilled that she's agreed to come and give us this lecture on cognitive screening and cognitive trajectories after stroke. Neela heads the Translational Neuropsychology Research Group at the University of Oxford, which researches the interface of cognitive neuropsychology and clinical practice in stroke. And Neela started this research group as an associate professor in 2016. And she holds an NIHR Advanced Fellowship on developing a post-stroke cognitive care pathway intervention. So a very warm welcome to you, Neela. Thank you very much for coming to present to us today. I'll hand
It's a
over to
pleasure.
you. I'll ask people, I'll just let people know that we will break about midway, Neela, for questions, and as well as at the end. And can you please use the Q&A function to ask your questions? That just works better from our end than using the chat function. So handing over to you, Neela.
Thank you very much, and thank you for having me. It's always a pleasure to speak to people working in stroke, and I really do enjoy talking about what we do. So it's always just a pleasure to present as well. So today I'm going to talk to you a little bit about post-stroke cognitive screening and post-stroke cognitive trajectories. And it's probably worth saying that if you were at the ANZO conference in Hobart in September, this will be quite familiar to you. But if not, hopefully this is new. Okay, so yeah, here we go. So as we know, stroke rehabilitation has really become quite the clinical priority, because what's happened so far in stroke research is there's been a real revolution in acute treatment, with thrombolysis, thrombectomy. There's been big revolutions in prevention. And what's happened is that's really impacted the mortality rate after stroke. So a lot more people are surviving stroke, a lot fewer deaths. However, what is needed at this point is rehabilitation, community care. What about those people who have survived a stroke? Many of them are left with ongoing disabilities, and a very large proportion of people feel very much abandoned. Stroke is still very much seen as this acute event, which get acutely treated. Once that's over, once your short inpatient rehab period is over, often people come back into the community and feel like this is not enough. They're still living with these ongoing problems from their stroke, but maybe haven't got continuous input. And this was really clear from a large survey that ran in the UK, which they surveyed 11,000 stroke survivors, with a huge proportion feeling really abandoned after they left hospital. Now, within those ongoing disabilities and ongoing problems, cognitive and mental health is one of the major ones. It's not surprising if you think that, the majority of patients after a stroke will have acute cognitive impairments, but also a very large proportion will have long-term issues with their cognition. And add to that 1 in 3 develop post-stroke depression. it's not surprising then that managing cognition and managing mood after stroke is the most reported unmet care need. That's translated in the UK and as part of the James Lind Alliance in setting stroke research priorities. So I don't know if you're aware of the James Lind Alliance, but it's a grouping here that does that for several disease areas. So they exist for diabetes, for cancer, and so on. But for within stroke, they basically bring together patients, clinicians, carers, some researchers, but really the majority is from the ground up, and they have large workshops and surveys and a whole series of methods to try and get to the idea of, what really is most important for you to tell us what we should be focusing research on. And so within stroke, the top two stroke research priorities for life after stroke were very much about those two major unmet care needs around managing mood and managing cognition after stroke. So in this talk today, I'll tell you a little bit about screening for cognition, why you should probably do it, what we've done in this space with the Oxford Cognitive Screen, and then in part two, how to follow up. So you've done your screening and what's next? What are the kind of trajectories to expect? How do we communicate with patients? So probably if most of you work in stroke, then I don't need to convince you that post-stroke cognition is really important. It really just affects everything in daily life. So if you're a physio and you have a patient with cognitive problems, that will really impact on their ability to learn new skills, to do repeated exercises, to manage their own kind of goal setting and make sure that they keep up and do the repetitive training, for example. Similarly, more broadly, when people go back home, their ability to drive, their ability to be safe in the kitchen, people going back to work, it basically, throughout everything in your life, you can imagine that post-stroke cognition will have an impact. So in terms of the research on this, here's just some papers and references. And I think the key bit here is that, people repeatedly within research find that these post-stroke cognitive impairments impact patient outcomes. Now, one of the big things that maybe is a little bit more surprising to people is that this is over and above physical disability, over and above stroke severity. So when you control for those aspects, then cognition on its own has a significant contribution to these kind of outcomes. Because sometimes people think, oh, it's just stroke severity, right? If someone's got a more severe stroke, they will have more cognitive problems, they will have more physical problems, so they'll have worse outcomes. But actually, you can separate out those elements. And so you find that cognitive impairment on its own contributes to lower likelihood of home discharge, lower likelihood of return to driving, activities of daily life, quality of life, depression, and obviously the most significant predictor of long-term post-stroke dementia. So what is it then? Well, you'd think you maybe know what post-stroke cognition looks like, but depending on who you talk to, you'll get quite different answers. And it's the same in the literature. If you look in the literature to the big medical journals like the Lancet and Stroke, you'll see that they talk about post-stroke cognition as this kind of unitary thing, this kind of thing on its own. They then typically have this along with some functional impact, and they will talk about post-stroke dementia. That's the usual term they've been using. They've moved more now to consider post-stroke cognitive impairments, recognizing that maybe not everything is a decline, and a lot of these impairments are stable. In contrast, if you look at the more neuropsychology and neuroscience literature, you'll find much more detail. People will talk about facial spatial neglect. People will talk about apraxia. People will talk about aphasia and all of the different types of aphasia. And then there's lots of this work around lesion symptom mapping, which kind of area of the brain is impacted, how does that relate to specific behavior? And those two things seem different, but actually they are the same. They're talking about the same people. They are considering the same patients within their research, and it's probably just helpful rather than contrast them of one side, other side, to see how it's more of a zooming in and a zooming out. You're either talking in broad terms or you're talking in a little bit more detail. Now, it has got some issues with it. And one of them is that, again, what are we talking about? Are we talking about these domain-specific cognitive problems you see after stroke? People have problems in language, perception, and attention. They've had a focal stroke that's related to a specific area in the brain. Those areas will impact these kind of functions. And when we think about how common this is, it's just very highly common, right? As soon as you see a patient after stroke, you can expect the majority of patients to have some of these issues. Now, in addition, there's many comorbidities. Stroke is often in older age. People have got pre-existing brain health issues. They may have pre-existing vascular dementia. They may have pre-existing Alzheimer's or mild cognitive impairment. They may have Parkinson's alongside. And so you get this kind of complex picture of cognition, which is both to do with their focal injury, the problem of the specific area of the stroke, as well as this overall brain health picture that is going on at the same time. So when we're screening for cognition, it's worth thinking, what is it you're trying to assess and why? Are you trying to assess their pre-stroke cognition? Are you trying to assess what's happened since the stroke? Are you trying to assess a combination? And why are you doing it? Are you just trying to classify them into dementia, not dementia? Or are you trying to use some of this information for informing the rehabilitation care pathway? So I'll tell you a little bit about the Oxford Cognitive Screen and why you might consider that as a first-line cognitive screen. So if we look back at some of the guidelines around cognitive screening and post-stroke cognition, there's many. I've picked out this one because I think it brings out quite an important issue, is that, as I said before, you can imagine cognitive losses are probably present. But these cognitive domains should probably not be considered in isolation. Most everyday activities draw on a range of abilities. So, it's no use just doing a large battery on neglect only without considering what's their memory like, what's their perception like, what's their language like. Now, when we started in this space, what typically happened and what probably still happens quite a lot around the world is that you can't really get neuropsychology to do long domain specific assessments because the burden on the patient is too high. You can't expect patients to sit through hours of assessment when they've just had a stroke, but also the staff availability isn't there. You don't necessarily have a whole set of trained neuropsychologists that can go and assess in depth every patient coming through the door. So practically, we turn to screening tools. So we use short screening tools, and the ones that are available and the ones that are typically used were the ones made for dementia. Now, remember that first slide about, the literature and the Lancet and the big medical journals. That's kind of how they conceptualize cognition, right? It's this one thing. It's either okay or it's not okay. But these screening tools were very much made for dementia, and the main emphasis is on verbal memory. And so you end up indeed having this kind of cognition pass or fail outcome. Now, when you're trying to do stroke rehabilitation, that might not be the most useful thing to have, or just a general number that reflects some sort of severity, but maybe doesn't reflect where the issues are. So there was a big emphasis in stroke to make sure we do domain-specific screening, and it's what made the MOCA really popular because when you look at the MOCA, you can see these kind of subdomains. They have like little subsections, and it feels like we're doing a bit more domain-specific screening. Now, just to remind everyone, a profile after dementia is not the same as a profile after stroke. And although it's got those little subsections, you don't actually have cutoffs for the separate subsections. You only have a cutoff for the total score because the norm data has never been made available. And you can't really say when they make some mistakes, whether that's actually meaningful within a normal space or not. Now, this one up here is probably the worst place to put a test for a patient with neglect. They will simply miss the 5, the D, the E. They'll just go nowhere near it because their attention is being drawn by this busy page. And so putting something in the top left corner will cause some contamination of your results. But mainly, it's really heavily language dependent. So if you've got a patient who's got an expressive aphasia or even word finding problems, you'll find that they more often than not will fail a MOCA, not because they've got dementia, but because they've got aphasia. Now, this has got implications because if you look at some of those big journals, this is a famous paper, has been cited, I don't even know, loads and loads of times around what are the factors associated with post-stroke dementia. And what you see quite clearly is these things around dysphasia and left hemisphere stroke. Now, there's no good reason to believe why a left hemisphere stroke or having a dysphasia will make you more likely to have dementia. What's happening instead is there's more likely that you will fail a verbal memory test because of the verbal aspect of the memory test. So it gets these kind of confounds, and they've got implications throughout in terms of how we interpret these kind of test scores. Okay, so when we made the Ox, basically we were trying to sit in between these two worlds, try and kind of bridge the divide and try and kind of bridge some of these silos of thinking. So we want something short that can be done in real worlds, but also that brings in some of the neuropsychology expertise and some domain-specific expertise. So that's how the Ox was born. So what it does basically is just briefly screens for these different domain problems, so there's some tests on language, on attention, on memory, on praxis, on number, but importantly, made for stroke, made to be able to be done with people who've got aphasia and not confounded by neglect. It takes about 15 to 20 minutes to do. It's been normed, it's been validated. It's free for publicly funded use. We've done comparisons to MOCA and MMSE, finding higher sensitivity and specificity, but also especially higher inclusivity and, like I said, less confounds on the test outcomes. One important thing to me always has been this kind of moving away from this dementia label, because we've seen it. We've had people call us and people talk to us saying, oh, my father's been told he's got post-stroke dementia after his stroke, and it's been now 3 years. And we are still waiting, when is this going to get worse? Because, he's got post-stroke dementia. And probably this may not be getting worse, right? That he's just got post-stroke cognitive impairment. This dementia label, due to that kind of nature of global screens, might not be helpful, and in fact might cause quite a lot of anxiety as well. So if we do the kind of more domain-specific screening and we talk about domain-specific impairments, what you get is an overview of the profile, which means you get strengths as well as challenges for patients. So you can say, oh, these areas are difficult for you, but look, you're doing really well in these kind of domains. It helps you to guide therapy and inform a care pathway. And again, allows you to measure recovery as well as decline. Because as we know, for example, aphasia will improve over time. Neglect typically improves over time as well. So you can kind of show people are improving on these kind of specific subtests. So this is some of our data from our early papers. This was on 200 stroke survivors and just kind of showing the kind of high impairment incidence we saw. Now, the ones in bold are the ones that you would not see in a dementia screen because you're expected to be able to read and write. That doesn't get tested. You're expected to not have neglect. That doesn't get tested. You don't test for things like apraxia. But you can see in all of those areas, obviously, there's very high incidence. And even if you then take, this was quite a small subgroup, people where MOCA was okay. So you would have said, okay, their MOCA's okay, cognitive impairment, no cognitive impairments. But then you look, and then exactly those kind of tests that you haven't been measuring, can they read and write? You'll find people have impairments. You'll find people have impairments on executive tasks. You'll find, in our case, half of them had neglect, for example. So you kind of really want to look not just at global cognition or a global MOCA, but also at these kind of stroke-specific issues. So it's become a really popular screen. So around the UK, almost probably actually all the acute stroke units have got the Ox. They may or may not use it with all of their patients, but it's become a very common tool. There's been a translation since 2023 in Australia, and that's meant a lot of take up across Australia as well. So you might already be familiar with some of it. But now maybe you've got a bit more of the background. So in terms of it actually being domain specific, this mainly came as a question from one of our reviewers at one point that said, oh, well, you say it's a domain specific screen, but is it really? And we thought, well, of course it is, because we've validated it against existing batteries and existing tasks that are very clearly measuring separate domains. But it made us think that we should do a bit of lesion symptom mapping, which we've done quite a bit of in the past. And all this was doing is taking people's brain scans. So in our case, 593 scans, which were carefully delineated by Margaret, which is why she gets a little picture here, because that was a lot of work. And then kind of relate those to different cognitive impairments within the ox. And so there's nothing new here, nothing we didn't already know. For example, that language is kind of related to these kind of networks in the left hemisphere. That's not a novel finding. The novel bit is that you can get this with the very brief tests in an ox, that even when you're only testing a few items in a very short screen, you find that these subtasks relate to known lesion mapping. Okay, I'm going to do a little bit more on how to follow up before I break and I talk about trajectories. So you might want to do some further screening and assessment. And this comes back to your question, what is it you're trying to assess? If you're trying to assess pre-existing dementia, the OX is probably not the tool for you, right? If you're trying to assess really subtle global cognitive changes, not kind of the very focal big changes after stroke, but mild changes in executive function, these kind of slight problems in concentration. The OX probably wouldn't be sensitive enough to pick that up. If you're trying to monitor long-term recovery and decline in primary care, maybe you need a different tool again. So as a reminder, the OX was made to do this kind of first-line screen. You've just had a stroke. What are the changes that this focal stroke has imparted? Made to be aphasia friendly, but things like, for example, the memory task is only scored on recognition, which is a multiple choice task. We've done that really specifically because we did not want to unfairly impact people with aphasia. We didn't want people with aphasia to always score poorly on memory because they aren't able to verbalize. So that's why all of the tasks, for example, are just recognition. Now, if you know a little bit about memory, and probably you all do, it's much easier to recognize something from a multiple choice than to actively recall it. So in terms of sensitive testing for memory, the OX probably doesn't do that, for example. So it's the reason we made the OX Plus. The OX Plus is kind of a follow-on screen for the OX. It's a computerized version. It runs as an app on the Play stores and the Google App stores. And it's set up to really kind of look at these mild impairments. So in terms of both verbal and visual memory, as well as executive functioning. So it goes through a set of tasks that gives you some input on these kind of more milder issues that might be going on, or these kind of, more global issues around memory and executive functioning. Because it was made as an app, it means that you can also take into account the kind of age-related cognitive decline that happens, the impact of education levels. So these are all the things that are needed if you want to do sensitive testing, because you can imagine that normal performance for an 80-year-old is not normal performance for a 50-year-old. So you kind of want to take those things into account when you're trying to look for subtle impairments. Because it's on an app, you don't have to calculate it yourself or go and look into tables. It just does it for you. And we made it from the start to be able to be easily adapted for translations and cultural adaptations. It's been validated in obviously healthy, but also now in stroke survivors, where we found some really nice data actually comparing it to neuropsychological assessments. So the full-blown much more in-depth assessment, and found that actually the rates of detection were very, very similar. So you get really highly sensitive screening with the OX Plus. So that's just a brief introduction to that one. I think it's coming. We're working on an Australian version but only just starting, so that it might not be there quite yet. The other tool we've just brought out is the mini-ox, and it's basically trying to look at these kind of stroke-specific problems for primary care. So it's a really short version. It was just out in August in European Journal of Stroke. The idea being that it's taking the best of the ox and the ox plus. So you have enough sensitive screening for the kind of domain general issues as well as domain specific issues, so you can monitor people long term, but brief enough to be done in a GP session, which here is 10 minutes. So it needed to be like 7 or 8. And so that's roughly what it is. So that's just come out. So just as a bit of an overview, because I know I've talked about a lot, the way to structure it probably is to say, okay, people have just had a stroke. Have they got stroke-specific focal problems? You do an ox, first thing you do. Do you want to know if they had pre-existing dementia? Then do some other testing, right? Either do something like an IQ code, which is basically a carer report. So you ask somebody who knows the patient quite well, what were they like before their stroke, and get an idea of whether there was pre-existing decline, or do something like a mock-up, but taking into account these are the stroke-specific focal problems. So if you think, okay, they haven't got any real clear issues that might impact this kind of screen, then it's probably a nicer way of looking at things like memory impairments through a mocha. You might want to look for these mild things, in which case you do something like an OX plus, do some more sensitive screening. You might still want to do a whole comprehensive assessment, right? You might have some very complex cases. There might be complex needs, people returning to work, really trying to understand what's the nature of the difficulty. You know, you've picked up something in these things, but you want to dig deeper. That's when you get your neuropsychology referrals in, and you ask and you refer down to neuropsychology for comprehensive testing. And then, yeah, maybe the mini-ox is a nice tool to consider for cognitive monitoring in the long term. Okay, I'll pause here for a minute because that's kind of my section on cognitive screening, and then I'll tell you a little bit about what happens after the screening, and what happens in terms of recovery and trajectories, and what might we do. Shall I stop sharing, or
That's okay at the moment, Neela. I don't have any questions that have come through yet on the chat. Oh, here we go. I've just had one come through from Locke. I'll just read it out because it's quite long. I have a 55-year-old female with bilateral MCA infarcts. Cognitive-wise, she was previously working and living alone, functioning well, limited family supports, currently non-verbal, and does not have a specific method of communicating with speech therapists as both expressive and receptively aphasic. I'm unsure of where to progress in terms of cognitive screening from just assessing following basic instructions. Any further suggestions or thoughts? Thanks, Locke.
yeah, my thoughts on that is around the time, right? So when people have got full global aphasia and real serious comprehension problems, there's very limited things you can do in terms of cognitive screening. In terms of formal cognitive screening. So I think what you're doing is exactly right, you know, trying to understand instruction comprehension and kind of following commands in these stages. So I'd say hold, wait. A lot of these things will improve. And so reassess and monitor until comprehensions improve to the extent that you can do a little bit more screening. So yeah, I think I often get asked, you know, when do we screen? And I will say things like, well, it depends, right? You know, if your patient's unconscious or non-responsive, then obviously you're not screening. If your patient's 2 hours post-stroke sitting up, ready to go, then 2 hours post-stroke is fine. So there's never an ideal time, and it's down to the patients to kind of figure out. But you can screen. We typically have in our inclusion criteria, for example, for our research, we will say things like if the patient is able to engage and kind of, you know, stay awake for about 10 minutes, you're probably good to at least attempt. So we'll attempt, and then if it turns out, for example, we start the ox and They have, so the way the Ox is structured is you start with a picture naming. So you show them some picture. If they can't respond, so you get nothing, you go, okay. The next task is a pointing one. So say, can you point to the tool? So if they can't do that either, so they can't speak at all and they can't respond to the first two items and kind of do pointing responses, then probably that's where you would stop and say, look, let's try and revisit this again. So I imagine that'd be something similar in the case of that patient. Um, you probably would have gotten 0 for the first task on the naming and probably 0 on the second task on the kind of pointing. And that's probably where you'd hold until a later time. Sorry, that was long.
No, no, that's very helpful. Thank you. We've got lots coming through now. The next question is, how soon after completing an OX would you suggest completing a follow-up assessment, i.e. OX Plus, to monitor cognitive progress or therapy?
Yeah, so it typically with us gets done at stages. So in terms of people will often redo right before discharge, for example, of an acute unit. In terms of a rehab unit, um, we'd say at least leave like 2 weeks in between before you kind of reassess on the same test. If they've flown through the Ox and they've got no issues whatsoever, but you think, they're going back home, they're going back to a high demanding job, there might be something subtle wrong. I do an Ox Plus immediately, like I wouldn't hold. So it depends. Yeah, that's always the answer, right? It depends. But I think in this case, um, I'd follow up with an Ox Plus immediately if the Ox was fine, just to kind of check, is there anything mild going on? But if you're just trying to monitor, they've got some issues on the Ox, yeah, at least 2 weeks in between, let's say, before you kind of repeat and say, oh, how's their neglect improved, for example. Um,
Okay, next question is from Rosa. As part of screening, would you take into account if patients have neurodivergent conditions that may impact on cognition presentation, for example, previous executive function abilities?
Yeah, definitely. Probably not on the Ox. I think the Ox, like that first line screen, is really looking for, has the patient got neglect? Have they got apraxia? Have they got, exec? Because the exec task in the Ox is quite a straightforward one. It's like, it's an interesting one because for very severe patients, it's too complex. For very mild patients, it's too easy. But I would expect that to be okay for people with kind of some pre-existing neurodivergence. On the Ox Plus, it might be slightly different, right? You might pick up things and you might wonder, is this the stroke or not? But maybe that's kind of okay, whether it's the stroke or not. You're just trying to assess, have they got these issues?
Yeah.
So yeah, take it into account as your background, but it would still be outside the norms, which would tell you something about the kind of issues they have.
Yeah. The next question is from Laura. She's asked, would the mini ox be suitable for use as a screening tool within a hyperacute stroke unit setting?
So probably unlikely in that the mini ox, the tasks, for example, around the executive ones and the memory ones are more Ox Plus like. They're looking for these subtle differences, and so it's a good question. So I'd say probably some of the tasks are a bit too hard to do in terms of someone who's just had their stroke. So I'd say stick to the Ox. It's only 10 minutes longer. It's still short,
Still
but
short,
I know
yeah.
I know there's pressure to do as quick as possible. But I'd go, the Ox is really made for that situation, this kind of acute picture. Whereas the mini Ox is kind of made for like following up someone who's already recovered some of that initial hit from the stroke and is in a slightly better place.
Okay. The next question is, and then we might move on back to your slides and answer the
Yeah,
remainder at the end, if
part
that's
two.
okay, Neela.
Yeah, 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 yeah.
The next one is, what is the work involved in translation of the screening tool? Nisha is in Zimbabwe and loves the Ox, but some of her patients don't speak English as a first language, and we struggle to screen cognition.
Yeah, get in touch, Nisha. There is a whole process. We've done it now for 23 different languages and cultural adaptations. It's basically you follow a set. There's documentation on concept elaboration. There's usually forward and backward translating and renorming. So there is quite a bit of work involved because we always renorm. So there's no so some screening tools, shall not be named, will just translate and assume the same norms apply. So whatever the norms were of the original population will be just applied to all of the translations, which we think is slightly problematic because you want a norm for that kind of language version in that kind of population. So it will always include some renorming. So yeah, a bit of chunk of work involved, but if you're up for it, there is a very clear manual process system to follow.
That's great.
Good.
Thank you, Neela. I'll hold on to the remaining questions until the end of the next component. So we'll move on to speaking about trajectories. Thank you.
Excellent. Thank you so much. Okay, so the next step is how to follow up. So this is around cognitive care pathway, and this is a lot of the work we're doing at the moment. And so it's all great, and we love that the OX is being used, and this cognitive screening is now part of guidelines, and it's clearly on most people's minds that, we should be looking at cognition, which is a big change from how it was, right? It used to be if you can walk and talk, you would go home, and nobody would really consider cognition. So great first step, but then what? What do you do with this information? And obviously we ask around, and what we typically find is that multidisciplinary teams will say, oh, we discuss it in the MDT. It informs our approach to patients. It informs our discharge destinations, for example. Is it safe? But what's not necessarily happening is giving you some idea about what to expect. So this question about trajectory. So we found these cognitive impairments, and what can we tell the patient about what this is going to look like? If you compare to if you break your ankle or something's gone wrong physically, you'll get something like, oh, you'll probably be able to walk again in so many weeks, but you probably won't ever be able to do ballet again because that ankle won't hold. Whatever comes out, people have got a very clear idea of how things recover and what you can expect. For cognitive problems, we really haven't got a very good idea here. We tend to say things like, oh, it might get better or it might not. We don't really know. Whereas, research should be able to inform us, and we should be able to do a bit better on prognosis. The next thing we don't really do much of is talk to the patient themselves about what we found, what are their strengths, what are their challenges, what does this mean? Often, especially in acute settings, we've done the screening, we've talked to our team about it, it's informed us, but maybe nobody's really sat down to explain to the patient and the carer what's going on there. And then management and monitoring is probably another bit where we need some improvement. So with all of those, that's not to say that this is how everybody everywhere does it. We're very well aware there's pockets of excellent practice where all of this happens. But in the majority of cases, it's probably fair to say that there's some work needed, especially on the management and monitoring. Kind of the way the stroke services are organized means, like I was saying earlier, it's this acute event, and then people go back into community and they maybe get some monitoring of their blood pressure and their risk factors and their medication, but not necessarily about these kind of cognitive issues. So hang on, what trajectories should we expect? Okay, so I'm going to talk to you a little bit about recovery and decline. I think actually, let me just skip a few slides because I was going to talk about cognition this first. Okay, back here. Apologies for the confusion. Right, so I'll talk to you a little bit about those two aspects, these kind of communication and prognosis aspects. Right, in terms of discussing cognition after stroke, this is just a small piece of work. We've done 2 papers on this, which is included interviewing stroke survivors and carers. So we interviewed 27 stroke survivors and carers about cognitive assessments, about cognitive trajectories. And a lot of the comments we got from patients is, oh, we don't understand why we're doing these cognitive assessments. Nobody really explained it to us. And then some of them said things like, oh, why am I doing these stupid things that, I'm here, especially early on. My issue is with my arm. and that's the main focus. So what am I doing these stupid things for? Um, Other people say, oh, it would be helpful to talk about cognition, just to kind of know a little bit more about what to expect, maybe have that discussion, just to be aware of what might be. We didn't have that discussion. So that's just obviously a subset of patients who felt like nobody really talked to them about this. Now, there is a little note to make here is that this is obviously in hindsight. So maybe somebody did talk to them about this, but they were overloaded with all the other information that they were being given in their acute setting. And this did not stick. So that is something to keep in mind. Um, Around the kind of trajectories, people were really worried about this cognitive decline and post-stroke dementia. I think we sometimes forget, if you think about those kind of papers I talked about in the beginning, in the Lancet and in Stroke around post-stroke dementia, patients Google too, carers Google too. They find these things like post-stroke dementia. They're very worried. They'll ask, what is this? Are we now at an increased risk? Um, and then, one of the comments was very much, oh, it's bad enough. I don't really need to get worried on top about, you might get an awful lot worse as well. You might feel like giving up if people talk to you about this chance of post-stroke dementia. So there's a lot there, and there's a lot there to consider. If you're interested, I really recommend you read the papers because there's a lot more quotes and there's a lot more going on. But it's this kind of balancing act between giving helpful information people want to know, but also not unnecessarily worrying people and really finding the right time to have these discussions. When is it the right time to be talking about these things? And it'll be different for different people. And you really kind of want to have a personalized approach to this rather than just treat everyone in the same way. So that's just a little sidebar about communication. But I was going to talk to you about trajectories mainly. So if we look at the old view of the literature and those kind of papers about post-stroke dementia, you'll see this kind of very simplified idea of people have no dementia, then they have a stroke. Some of them get dementia, some of them don't. And it's basically just used a single screen and, whatever the cutoff is, they're below or they're above, so they either have or haven't. And that's where those kind of prevalence numbers come from. That's where those kind of associations come from. And you'll see these kind of prevalences based on this picture where things like, if there's a severe stroke, 34% of patients will have dementia. If it's a minor stroke, it'll be 8% and so on. But yeah, basically based on having done a MOCA at some point after their stroke. Now, the more updated view has been that, of course, people are on different trajectories before their stroke. Some of them may already have severe cognitive decline before their stroke. Then the stroke happens and you have these early cognitive issues, as they are deemed. Some of them recover, there's stroke-specific delirium, that will improve. So you get this kind of improvement early on, and then varying trajectories, including this kind of stepwise decline with further insults. And obviously that's a nicely updated model, but it's still very much in that view of cognition is one thing. Whereas, as hopefully you'll be on board with me now, cognition is many things and many aspects, and some of them are related to that focal stroke, and some of them are related to global decline. And you're kind of mixing it all up, putting it all together and losing some of that detail and trying to understand what is it that's improving and what is it that's declining, because it's very, very possible that some aspects are recovering really well. So, for example, their aphasia is really improving, their neglect's really improving, their apraxia is getting a lot better, but at the same time, their memory is getting worse, and the memory is related not to the stroke, but just to the overall atrophy, overall brain health. So what you get because of that kind of one model and this kind of trajectory is this research focus in clinical stroke research is around risk prediction. So a lot of it is risk prediction for dementia, borrowed from the dementia literature. Say, oh, we've done all these factors that relate to dementia in healthy aging. Can we do the same in stroke? what we're not doing very well on is predicting recovery, and it's again this kind of focus of we're trying to predict the risk, but we could also try and predict recovery. And again, that's very clearly this difference in the journals. The big medical journals are all about risk prediction of dementia. The more specific journals in neuroscience and neuropsychology will all be about predicting recovery. Now, interestingly, if you're into this world a bit, which maybe not many of you are, but they're obsessed with finding these predictions of recovery based just on the scan. So it's this driven by neuroscience saying, oh, if you have the scan and you can see where the area is that is damage, can we predict recovery? Can we predict plasticity based just on the scan? Which is such a, in a way, strange approach, because if you could do it on the standard things that are available to everyone, because the scan, it requires you not just to have the scan, it requires you to do the delineation of the lesion, and then to normalize, then to stick into a system, then to stick into another system, and then hopefully you get some output. But that's never going to happen in clinical practice. That is, can you imagine people sitting around delineating? So then they're trying to make these solutions where we're getting automated delineations. That's not doing too great. But I'm hopefully going to convince you that there's a much cheaper and easier way, and that's just to look at behavior. So this is some of our data. So we've been running since 2012 acute recruitment and a cognitive screening program where we see them again 6 months later. So we see them acutely. We have some brief screening with the OX, and we take the scans as well. We get the stroke characteristics, the demographics, and we see them 6 months later. We do a bit more elaborate cognitive screening. We get some outcome measures. And then actually a subset of them we followed up long term. So at that point, anywhere between 2 and 9 years post-stroke. So we have 3 times of following people up across people who've had their stroke and have taken part in our research. Now, the kind of cohort we have, so we started with 866 people, classic 85 ischemic, 15% hemorrhage. That's kind of what you find in overall in stroke. That's kind of the proportions you have. Our average age was 74. Our median stroke severity score on the NIHSS was 5. There's this interquartile range. So we kind of get the moderate strokes probably in, although we have got tails with more severe strokes and with very light strokes. And so this kind of cohort we saw typically with the OX within their first week, so on the acute unit. So yeah, average days, 4 days after stroke for doing the OX. Now, for us, that's a representative sample. That's in line with our national stroke audit stats. So that was kind of the aim. We want to get anyone and everyone who comes through and just get the picture of the clinical reality. Now, what does that mean in terms of losing people down to 6 months? We have about 50% attrition. So what ended up happening is we did very inclusive recruitment because that's the clinical reality. But then when we tried to follow people up 6 months later, we find that we lost both ends of the tail. So the very severe strokes, series of people passed away or were too unwell. As you can see, quite a few people were lost on that side. And then we lose people on the other side who are saying, well, actually, I don't want to be reminded of my stroke. I'm good. I've recovered. Thanks very much. So these kind of milder strokes who've gone back to work and who are feeling okay tend to also not complete 6-month follow-up assessments. So we're left with a core people completing, but it's kind of, again, the average. So that the average numbers haven't changed much, but we've lost the tails. So in this cohort of people, so the 430 that have done both acute and 6 months, that's what the data I'm going to talk to you about relates to. So this paper came out in International Journal of Stroke last year, and this was around the value of cognitive screening for predicting these outcomes. So if we look at our data, so acute in 6 months, we see that there's fewer people impaired at follow-up than there are impaired acute. So there is clear signs that people are improving and that there is recovery across all of the tasks, across overall pictures, if you think about any domain impairments or multi-domain impairments. And so we did some work trying to replicate what people were doing around this risk and this understanding the chances of people being cognitively impaired at 6 months. So in the first instance, we just said, oh, let's take the base model as they do typically in stroke research. So all of the risk factors. So this is things like atrial fibrillation, diabetes, smoking, yeah, anything you can imagine, anything that you know is related to stroke typically gets used in these kind of prediction models to see, oh, can that also predict cognitive outcomes? And this is the base model. And what you find is the only predictor really is age. So the older you are, the less high your the worse your cognitive impairments will be. Now, this adjusted R-square, for those of you not in research, what that means is how much of the outcome is being explained by the model. So that's about 10%. So you just basically do times 100 and say, okay, about 10% of the outcome data is being explained by this model, which is not a lot, right? So you have all these variances of cognitive outcome at the end, and this model, basically age explains about 10%. Now, when you stick in acute cognition, unsurprisingly to us, but surprisingly to a lot of people, that jumps about 30%. So you're explaining a lot more variance. And obviously, acute cognition will predict long-term cognition. So it seems like a no-brainer. But like I say, the way that these models are typically run are trying to use either just clinical factors or on the other side, trying to use imaging to try and explain. But actually just using the cheap behavior that you have gives you quite a nice model and really tells you a lot about what's going to go happen. And so in terms of clinical practice, the more severely cognitively impaired somebody is acutely, the more likely they will still have issues 6 months down the line. Luckily, just after we published that, a nice systematic review came out trying to look at relative risk scores. So this was in the Lancet Healthy Longevity, and you can see all of those factors that you normally see, the diabetes and the hypertension, etc. And so what's happening here to try and understand what's happening in this graph is the pooled risk ratio means, the higher that number is on the y-axis. So up here, I don't know if you can see my mouse, the more this factor contributes. And the risk ratio on post-stroke dementia is on the other side. Same for post-stroke dementia as for post-stroke cognitive impairment. But crucially, look what's here. The biggest predictor is baseline cognitive impairment. So same as what we found, but found in a much larger space and in a nice systematic review. Now, there's clinical implications, and I don't think people are necessarily taking them up yet, but hopefully we try and get this message across, is that actually acute cognitive and screening information can be used in a care pathway. It can inform who needs monitoring, and it can maybe help extend the focus away from just doing medication management to cognitive monitoring if you know these people are a higher risk of having continuous problems. Okay. A little note on our long-term follow-up. I know we're nearly reaching the end. This is looking at the subset. So I told you, we lost a lot of people. We're at 430 at 6 months follow-up. And when we applied for this funding, we had gone through that list and seen at that time who had consented for additional research, and that was about 208 patients. So when we applied for the funding, we said, there's 208 patients we can contact at this point who said they'd be happy to take part. When we got the funding, and then by the time we ran the study, which was probably a year and a half later, this was down to 105 because another proportion of people had passed away, were too poorly, or were just generally lost to follow-up. So this is only on about 100 people. So the numbers are getting a lot smaller, but they have got acute 6 months and long-term follow-up. So it's nice repeated data. As you can see here, in terms of their stroke severity, their acute NIHS on average was about 7, so definitely on the moderate end, the people who are still in the stroke study at this point. And on average, they're about 73. And this is some of the kind of picture that's going on. So this is number of people impaired, acute at 6 months and long term. And hopefully what you can see here is that in some of the instances, like language and memory, you can see continued reduction of people's rates of impairment. We've done some more clever things on it, which I may or may not have time for. But if you think about just looking at impairment status at this long-term picture post-stroke, about half of them would still have impairments on the OX. 65% of them scored less than 26 on the MOCA. A third of them scored less than 22 on the MOCA. So you'd say, oh, this is quite a cognitively impaired cohort. But if you think, oh, do they all have post-stroke dementia? Then that's probably a very different picture, because actually what's happened to these people is the majority have been improving, not declining. And so determining their status on the one-off measure is not very helpful. That's why you have the repeated measures to see what's the change over time. So you remember this. So yeah, you'd basically end up saying about half of them have got post-stroke dementia in our cohort, which I think a lot of our patients would very much disagree with, and I would very much disagree with. This is the modeling we've done in terms of recovery, and as you can see, the majority, so these single lines here, they're all individual data points, and you can see the majority of people are still getting better between 6 months and 2 years. There is a small proportion, there's about 5% of our cohort that shows a clear decline. So there is definitely decline as well. It's just that the majority of those people who've got impairments are either stable or improving. So that's probably the message that is worth saying, is that yes, it is highly prevalent. It remains highly prevalent long-term post-stroke, but for most patients, this is improving or stable. And we see continued long-term recovery, which we would hope gives a message of hope and optimism for stroke survivors, alongside all of the literature on post-stroke dementia. So note, of course, we have lost many people, and this is a selected subset, so it's worth being aware of that. And this is my takeaway messages. Good, 1 minute before time. If you haven't remembered anything and you haven't got time to listen back to everything, just this slide. This is all you need. This is pretty much what I've been trying to tell you today. Acute post-stroke cognition is the strongest predictor for 6 months cognition, far more than clinical and demographic markers. So having an idea of people's acute cognition will give you a good idea what they'll be like 6 months down the line. There's cognitive trajectories that include a lot of cognitive recovery as well. I didn't talk to you about the brain health markers, but that's still in from my previous talk. I'm very sorry, I didn't have time. But yeah, the big takeaway as well is this kind of research definitions of post-stroke dementia should really include repeated measures, because you want to determine decline over time, not a single time point. Next time I'll tell you about my cognitive care pathway, and I'll just end by thanking the team behind all of this work, because obviously I'm not just doing this on my own. So thank to you also for your attention, and thanks to the team.
Thank you very much, Neela. So much fantastic information.
Sorry, I realized that I had more than
well, it'd be hard to cut it down, because it's it's been such an amazing body of research. Too. I'll hand over to Lauren to bring up some of the questions, if that's okay.
Thanks, Simone. Yes, I realize we're going a couple of minutes over, but that was so fantastic, Neela. Thank you so much. And I think some of these questions are very relevant to clinical practice, and it's great to see that people have clearly gotten a lot out of the webinar. So the first question is from Josie, and a second person has a similar query. So for the follow-up group within your trajectories study, did those people receive any kind of cognitive retraining or treatment targeting cognition, and whether that might have had an impact on the outcomes?
Yeah, we get asked this a lot, and I think that's maybe because there is more of this kind of input where you guys are than where we are. But no is the short answer. So no, they were just standard care. There's very, very little cognitive rehab here unless people go private and look for it. It's definitely not part of our standard pathway. So yeah, I think what that gets to is we might be doing even better in terms of cognitive recovery if we were to be
Yes,
able to input. So it's already nice that things are naturally, semi-naturally getting improvement, but we might be able to affect an even bigger
an
change.
even bigger change, bigger improvement.
Exactly.
Great. Um, Someone had asked earlier, which I think you touched on this within the second part of the presentation, Neela, but are there any specific prediction variables to keep an eye on from the initial days of care to perform early detection of cognitive changes? But it sounded like one of the only variables was age. Is that
Yeah.
correct?
That's the only thing that comes out systematically. And I end up reviewing quite a few papers of other people doing prediction modeling, and age is always there.
Yeah,
So, but that's, I mean, it makes a lot of sense, doesn't it? That people who are older will do worse cognitively. Um, but, and I think a lot of the medics are looking for these modifiable factors, right? So, because you can treat AF, you can treat hypertension. So, there's always the hope that that will make a big difference, but it's just so teeny tiny. I think that systematic review probably gives a good overview of the things that they're hoping for. Let's see if it's still here somewhere. Yeah. So, yes, white matter hyperintensity. Yeah, the left hemisphere thing is obviously, again, people tend to
confirmed.
do worst on a cognitive screen if they've got a language impairment. Whether that means they've got post-stroke dementia, we'll leave that there.
Mhm.
But yeah, baseline cognition is your best predictor, um, by far.
Okay. And then Hannah has asked, with the translated Ox being slightly different language to the Australian version, she's then put in brackets, I think, how does it work with an interpreter? Do you just get the interpreter to read straight from their copy of the assessment?
Yeah, these are really good questions around how we deal with those things. So there is various different language adaptations, and ideally, obviously, both the examiner and the patients speak that same language. Whereas in reality, if you're using it, say, in an Australian setting with people with a different language, you would have interpreter help. And that's practically how you would do it. There's no real research to show that gives you exactly the same thing because they're too little in numbers to, yes. But that's typically how you would do it. Yes, you'd have your interpreter go through with you and go through alongside. But yeah, it's a bit messy. Um,
Great. All right. Well, that's all of the questions that we have there in the Q&A at the moment. So I'll just hand back to Simone to close this evening.
Well, I'd just like to close by saying an enormous thank you to Nila for sharing her knowledge and her research. And I'm sure people will have gained an enormous amount of help for their clinical practice from your presentation. So thank you very much for preparing this and giving up your time to present it.
no, pleasure. Thank you for having me. And apologies for the bit of slides that went wrong.
Not at all, not at all. Okay, well, thank you, and to let everybody know that that it will be recorded. So if you want to go back or share it with colleagues in your workplace, that the recorded version will be put up on the Stroke Ed website within the next week or so. Thank you very much.
Thank you all for coming.
Thank you all.
Bye.